This is a show about the diversity of academic and experiential backgrounds of people working in patient safety. My name is Ivan. I am a lab rat turned infection preventionist. While struggling to find work, I reached out to a friend for support. Our chat turned into a LinkedIn post that showed me that many people in our field were in the same situation. The purpose of the Safety Spectrum podcast is to celebrate credential, educational, and experiential diversity, to share the values and success stories of non-traditional staff in quality patient safety and infection prevention, to advocate for competency-based versus credential-limited hiring, and to increase awareness of the importance of the infection preventionist and other roles in the healthcare safety sector.
My guest today is Karen McGoldrick. She's an IP at Sentara Hospital. She has a Bachelor of Science in Microbiology from Texas A&M University, is a certified medical technologist, is certified in infection prevention and control through APIC, and is a certified healthcare operations professional through DNV. I have Karen as a guest because she's a fellow lab rat, and because the Sentara Healthcare system has done a very good job of maintaining a diversity of backgrounds in their infection prevention programs. And so we're going to talk about Karen's career and the experiential range of the Sentara IP team and how they have normalized that. Welcome to the Safety Spectrum. All right, good afternoon. My guest today is Karen McGoldrick. I met Karen through the Sentara Healthcare system. She has been at Sentara Lee and Sentara Williamsburg, and I was at Sentara RMH. We were the new kid on the block, as it were, and Karen was one of the IPs who helped us kind of get integrated into the Sentara system. So, Karen, welcome. Thank you for joining me today on the Safety Spectrum. And we are going to dive right in and ask, how did you get into infection prevention?
I had worked in the lab, but then I had also, for a while, had done a lot of part-time jobs and different things and raising kids. But really, before I went back to the lab, I really wanted to have more interaction with people. So I first started out teaching medical assistants in a proprietary school of labs, basic labs, how to draw blood, but other basic medical things like, medical terminology, office skills, things like this. So I had some of that. And then I got into what I thought at the time was going to be my dream job, was teaching high school students healthcare careers.
Okay.
And I had a really great opportunity. It was a new school system. It was a brand new school, not a new school system, a brand new school in an area that was pretty premier for that state and everything. And so they had just really invested in this awesome program. And I enjoyed it. I had students of all different things. I would teach lab skills, but I would teach basic healthcare things. I taught terminology. Every Friday, I'd give terminology tests to those students. They hated it. but
Friday
they learned.
pop quiz.
And then my husband is a minister, senior pastor, and I said, God has a sense of humor. He wound up moving us to a new church that called him to be their pastor here in Virginia Beach.
Okay.
That was someplace I'd never lived before.
Mm-hmm.
And here, the schools, it wasn't the same type of thing for the school. So I really kind of missed that, but I was just waiting. I went back to the lab. I said, I'm waiting for the right thing. And I had a good friend from my church who worked for Sentara, who also was really good friends with the director. And she said, I think you would be perfect for one of these jobs. And so one came up close by. I interviewed, but somebody with a lot of experience got it. But the director said to me, I really, watch, if we have another opening, please apply. So I did, and that was Williamsburg, and it was an hour drive each way each day for that job. But once I got into it, I loved it, and it was worth it. Things are a lot worse than driving for a job, as we all know. Some jobs could be, and the job I was in, I was ready to definitely be out of. So it was a great experience. I did not know what I was getting into.
Uh-huh. So straight out of the lab into IP because of a recommendation.
Right. It was right. And a lot of it is, this happens a lot of times because I know a lot of people struggle. I want to get into infection prevention. I can't ever get an interview, or I can't ever seem to get the job. And I know that is a struggle with a lot of people, but you really want to just keep trying, just hang in there, because sometimes it's just the right person and who you know. It does make a difference with getting in. I mean, I came with a good recommendation, had a good interview, and I don't think they had many other apply at that time. That probably helped.
Okay.
Because that's happened. I know some people that have gotten the job, there just haven't been many applicants, and other times, so recently we've been hiring where I am at Lee, and for the second IP here, plus for the person that will be eventually replacing me when I retire. And we were amazed. We wound up with a lot of applicants. Only one really had experience, but others had lots of varied backgrounds. So it was really good to look at all the strengths and weaknesses from all those different ones.
Okay. I am going to kind of go a little bit aside and talk about this position that you're hiring for, and what kind of backgrounds have applied. And, how are you guys considering all of these applicants?
So we had one RN who was already certified. We had a couple of RNs, but for various reasons, they kind of back off of it a little bit. And honestly, I'm going to be honest about it. If you have RNs that have manager jobs or higher level positions, pay is not the same. So sometimes RNs, some of them are happy to get the Monday through Friday job and not have to work weekends and shifts anymore. But sometimes, and if you're a manager, you deal with all that headache. But sometimes that is a difference. Sentara is getting better about increasing our top scale and bringing it up a little bit. But that was something that happened. A couple of IPs positions here and other places wound up not taking the job.
So IPs get paid less than
an RN.
Higher RN. Okay.
It depends on what level the RN. So our IP jobs are just entry level clinical IPs. We do also have what we call surveillance IPs. We haven't really had an opening in that a while, but for our clinical IPs, I think we're not paid badly. I think in comparison to some others in the market, I do know we pay better than some of the other hospitals, but I think some systems, and maybe it's because they have only RNs, I don't know, that maybe they may have a higher scale. I'm not sure. But we've had several people with MPHs, but they were doing other things. One's working in the lab. In fact, there were two that applied from that had from the lab. One had a teaching background and had been a teacher in the public school system, and one had a new MPH and had done a lot of the things with the lab. Another MPH that was working doing different other things. One MPH that was working in environmental health in the health department. I'm trying to remember some of the others. Not all of them were MPHs, but a lot of them had a lot of varied backgrounds. One person worked a lot of things with COVID and with FEMA and some things like that.
Oh, so wow.
Just a lot of,
that would be some interesting experience there.
Oh, and there was even a person that had been a respiratory therapist.
Nice. Nice.
And was working on her MPH. So,
okay. All right. So there is a lot of interest in IP as a profession.
Yes.
We definitely cannot discount that. All right. So you have finally made it into IP, and you had to take the CIC at some point.
Yes.
Tell us about how you prepared for the test to start.
So when I started, it was required for CBIC that you had to have 2 years experience as an IP before you could take the test. Now they don't have that requirement. They just recommend it. So I did wait the 2 years. It was actually 3 years before I actually finally took the test. But I knew one of the things was I needed to do more focused training. I had great mentors because I was at a hospital by myself because I was the only IP. It was a small hospital. It was about 120-bed hospital. It was a great place to start and to learn.
Oh, yeah.
Because when you're by yourself, you have to learn everything.
Yes.
Whereas if there's two of you, sometimes one person kind of is the lead in one thing and somebody else in something else. So definitely I learned it all. And it was a small community hospital. And then I knew that I needed to do some other training, but also about that time, Sentara Williamsburg became the first Sentara hospital to switch to DMV. And one of their big things when they have their sessions with infection prevention is they want to know what kind of education that you're getting annually, and are you a CIC?
Yes, they definitely ask about that.
And I said, I'm not quite there yet, but I'm getting there. And so I did get Sentara to pay for me to go to one of our state conferences and to do the training. They had a CSC prep course on a conference day. And then I got them to pay for me to go to EPI 201 that APIC sponsors. And that was really good, just extra help nailing down all the things that I needed. And then beyond that, it just becomes studying.
Yes.
Taking practice tests, studying, practice test over and over. I remember reaching the point, and then part of it is signing up. So when you sign up, you have 90 days.
Yes.
And I signed up thinking I'll be all prepared, and a lot of things happen in the meantime, and I wasn't as prepared as I wanted to be. And so I was just going to not take the test. And I had one other fellow IP say to me, what do you have to lose? Go ahead and take it.
Yes, exactly.
And then you'll be a learning opportunity. And amazingly, I passed.
Wonderful. That's wow. Yeah, there was a little bit of a roller coaster there. And you did the group course through APIC Virginia, and then EPI.
It was actually through National. Oh yeah, this one with APIC, the small one with APIC. Yes, it was a 1 day, but the 201 was several days through National APIC. Yeah, sorry.
Yeah, I remember taking those classes and at the time thinking how great it was that Sentara was willing to send us out for trainings like that. A few colleagues who were not in the Sentara system kind of had to pay for things like that out of pocket. And I met a few IPs who did, and I'm like, I could not afford this.
No.
So yeah, that was a great opportunity. So any pointers for someone who is preparing to take the CIC or APIC or any of our many certifications?
Yeah, you never feel like you really know it all. So like everybody always says, you just do it, you don't want to take it without preparing, but I would recommend. Now, when I took it was in 2011, 12. It was right, I think, January of 12 when I actually took it. But I'd been preparing all in that fall. So I think nowadays they probably have more interactive and better study things. At that point, you bought a study guide and then you had practice tests you could do. I think it's better now with some of the practice tests and the way they can do so much of it online. Better.
Yes. Yeah. There's a lot more content online.
Right.
I took my test 2013, and back then we had like the practice book.
Right.
And so I took the practice test, the whole practice test, before I even started studying. And I did that so that I could determine which sections I needed more work on.
Yeah.
So for example, the microbiology section, identifying microbes and stuff like that, that was old hat being a lab rat. And so after I did that, then I went back through all of the chapters. I started with the ones that I did the weakest on, and then went through the whole study guide. And, but yeah, it took, I do not remember exactly how long it took me to do all of that, but I was just finishing grad school. So I was in a very study mode. I could read and understand words. Now, not so much anymore.
I think what helps too is if you're an infection preventionist, hopefully you have an APIC chapter somewhere that you can be part of.
Yes.
And so many of them offer study courses, different things that they would do. We used to, so APIC Virginia would do once a year nuts and bolts, and they would call it, and it was the day before the state conference for those that wanted to have study, for certification, or at that time recertification. Now,
Yes.
I think that really helped. I think being in
Recertification.
study groups helps. And our APIC chapter has also developed a mentorship program, which I'll put in a little plug. We combined with the Department of Health and have a joint thing with them. And so at APIC this year, they will be doing one of the presentations about that.
Very nice.
But
That's
I think
exciting.
that is helpful because they don't take brand new IPs. They take people that have been in at least a year.
Okay.
Because it's hard to mentor someone and have where it's a shared mentorship. So they're kind of helping each other. You're mainly helping the newer ones, but it's helping each other. And they can't do that much if they really truly, the first year you don't know what you're doing, honestly. That's one reason you shouldn't try to take the certification exam in the first year.
Yes.
But once you've gotten into that, if you can find something like that, that would help you with knowing what you're weak in and what you would need to study for. But I did the same thing, like you said, did the practice test, said, oh, this is something I'm going to need help with, and really focused on those areas that were
Environment of care.
Yeah. Got that covered with that chalk, though, now. Let me tell you.
I know, right?
Yeah.
Nice. All right. So, what do you find is the value of certification? You have been hiring. What differentiates, a certified applicant versus one who's not certified, and how much does their background kind of matter if there is a certification in place?
I will say this, and this is just infection prevention in general, but especially that certification. That certification gives you that recognition that you are a subject matter expert and people will listen to you. So just today I was thinking about I had to go basically bless off an OR that had water damage, and they wanted to be sure everything, it was in labor and delivery. They wanted to make sure everything was ready. They didn't open it back up without infection prevention saying everything was okay and taking a look. I mean, it was spotless. Everything was great, but they have that mindset that we need infection prevention to sign off on this before, rather than the other side of it. Something happens, something gets repaired, you find out about it, and you come in and go, y'all didn't do this right.
Not ready.
Nobody wants to hear that. So having that certification gives you that credibility. And I do remember one of the friend that actually got me in the door for getting the job saying to my husband after I got hired, she said, Karen's set for life. Wherever she goes, whatever she does, she'll have a job. She's going to be an infection preventionist. And that's before I'd even got my certification.
Nice.
So she knew how important it was that people always look for an experienced infection preventionist. So,
yes, absolutely. And yeah, you can work anywhere, just like lab too, but nice.
I will say as we've been interviewing, that was part of it. And we've had several openings. Sentara a lot of times goes years and years with no openings. And we have had several people retire, several changes around, different things. And so I've helped with a lot of the interviews, a lot of the hospitals. And I will tell you right off the bat, if a person applied that had a CIC, they moved to the top of the interview list right off. That was somebody seriously we looked at. So having the certification helps get your foot in the door in any other job.
Nice. Did you have any applicants who have the associate AIPC?
No, we didn't in this case. Okay. We had some that were either studying for it and hadn't completed it yet, and some didn't really have acute care inpatient experience. They had worked for the health department or something, but they did have their CIC. So even though I didn't know if they had acute care experience, they had a CIC, and that helped move them up right there, just so we knew that they knew the stuff,
Yes, exactly. Nice. So part of the reason we're in this conversation is because during the time that I was at Sentara, I was struck by how many Sentara hospitals who had more than one IP had a nurse and. right? And then there are many Sentara hospitals, Lee being one, was it Williamsburg, where you were the only IP and you're a lab. And many other IPs in our ranks at the time were from the lab. There were very few nurses, right?
It's still, I would say, we might have a third or less that are nurses.
Okay.
And probably we have quite a few that are MPHs. Some of them have like biology or something background and then an MPH, but they weren't clinical. They didn't come from a clinical hospital setting, before that. So quite a few from the micro lab. And some just from a lab in general, not necessarily micro. So I would say it's only about a third.
Yeah, which is backwards from the rest of the industry. Like the rest of the industry is 2/3
Yes.
RNs and 1/3 all the rest of us. So how do you think, just by your observation and your time at Sentara, congratulations on 14 years at Sentara, Lee. Well done. In your time at Sentara, how have you seen all of this play out? How did that happen? How is Sentara so different from all of the other healthcare systems?
I don't know, because when I came into it, the director at the time that hired me was also from the lab.
Okay.
And I didn't know it was that unusual. I do remember her saying that they, at that point, it wasn't hard and fast. They had some nurses. In fact, when I worked with later, when I came to Lee, the two of us, he was a nurse and he had been infection prevention for a while. So, it kind of varied. But she had made the comment that it seemed like a lot of times, and sometimes we have somebody from the lab that didn't stick it out either. But infection prevention is a very unique job, and sometimes it's not a right fit.
Yeah.
And people know it. Recently, one of the positions, there was an RN. He lasted 2 weeks and decided it wasn't for him. And that's a record. I don't think anybody's left after 2 weeks. But that did happen at one of the other hospitals. So they had discovered that a lot of times when they come from the lab, or also MPH ones, this is something they really wanted to do, and they weren't looking for anything else. A lot of times nurses kind of stumble into it, like maybe, oh, this is a good job for you, kind of a thing.
You don't want to be on night shift anymore.
Yeah, right. And if there's not any opportunities, they're a nurse. They can still go be a manager of a unit. They can be a director somewhere. They can go into quality. They can do a lot of different things. Whereas from the lab, you don't have as many opportunities. So
that is true.
When we left the lab, most of us, and the ones I've talked to, we didn't plan to go back, So this was something we knew we were going to make this jump. And this newest person that we have that's starting next week actually has come from the lab too. So it'll be interesting to, hopefully she'll stick it out.
Yeah.
But I think that's part of it. Nurses tend to see the side of it that they see that infection prevention is looking at isolation and who's wearing PPE, and they're checking lines and they're checking Foleys and watching for CLABSIs and CAUTIs and C. diff and all those kinds of nursing aspect of it. They don't realize how much is environmental and how many floods you have to deal with and constructions and ICRA, or how many visits to the OR, or all these other things. And so I don't think they really understand what they're getting into. So a lot of them really miss the nursing aspect, and that's what they go back to,
Yeah, we had, so when I worked at Sentara RMH, the senior IP, Becky, nurse, and she hired me from the lab, and her job description was specifically looking for someone from the lab.
Wow,
and when we talked about it later, she mentioned how she had worked with someone from the lab before me, and that partnership was so good because my lab background brings in a lot of micro, a lot of other test analysis, right? who do you call when you don't know whether it's bacterial or viral meningitis? You call a lab rat.
Right.
Right.
Well, what is that gram-positive coccyamine? I forgot.
Exactly. And so because of that history, we definitely supported each other a lot in surveillance.
Right.
I was able to kind of pinpoint microbes and things like that. She was able to interpret the nurse's notes and the physician's notes, and I think we definitely learned from one another as we worked together. And so that was a great partnership. It definitely helped with surveillance. And I heard you kind of mention a similar thing about back in the day when, so tell me about that.
So, and I will say, I can talk about how I wound up into it and how this happened, but also even currently right now, we are, as IPs, we are system IPs. It's different than when you were there. So we don't belong to somebody specifically at each hospital. We all belong to a system director. So, okay. Which is really awesome because we're all on the same page about everything. And whatever the policy is, it should all be happening at all our hospitals. So we have a Teams chat. Well, we have a fun Teams chat, and then we have a serious clinical Teams chat, and then we had the surveillance had their chat, and then they have a chat with both of them. So all day long, sometimes it's a little much because some people get carried away, but everybody's asking, sends a picture. I just found this in this clean supply room. What are you guys doing about this? Or can you believe one more time somebody's wearing their mask under their chin? I don't know. It's just something that we all want to beat our heads on, but we all recognize it. So the good thing is the nurse jumps in with what they know. The former ICU nurse can talk about that perspective. Those from the lab can talk about that. MPHs can talk about maybe some other things. Even though I had a micro degree and was from the lab, I also had a lot of experience working in hematology in the lab.
Yes.
So there's a lot of times I will look at things and I can know based on what the white count is or what something is, what that means or different things we're looking at. So we all have different perspectives. And then just even helping somebody out with how do you educate or what's a good way to train something. Those of us, and there's been some others I found out that had teaching backgrounds. So sometimes that helps with that. So Tracy, our director, has just over and over said she loves how varied our team is and how everybody brings something, a different viewpoint of way of looking at it, perspective or whatever, to the discussion. So it's really good.
Diversity for the win.
Yeah, absolutely. We are very diverse.
Yes. No, it's that's nice.
And what you were referring to of how it came into it, when I came into it, the director was, like I said, was from the lab. There was another person from the lab of the system. At that time, there was probably about 8 or 10 total system ones, and most of them were lab. There were a few nurses.
Okay.
But like I said, I think when the director first started, from what she told me, was that they had somebody from the lab when surveillance was first starting, and they needed to know how are we going to report what before it was called NHSN, and it was what that was going to be reported. And lab was who started it, and then they kind of pulled in some nurses to help them, and then it kind of just went from there. One of them they made a position for infection prevention, and made a director for the system, made some for each hospital, and that's how it got the ball rolling. But it actually was the lab person that was first looking at the surveillance of what was going to need to be reported to NHSN.
Nice. That's a wonderful piece of history that I'd not heard before. But yeah, so that probably birthed this culture of diverse IP backgrounds at Sentara. Nice. So you are slated for retirement.
I've been saying that for a couple of years, but I think it actually is going to happen this time, mainly because they've hired my replacement. I can't back out now. I had talked about it a year or two ago, and then there were some changes with the co-person working with me, and then some other things that were happening, and I'd actually have been actively involved, and that's another thing I would recommend to anyone, not just getting your CSE, but just to develop more as an infection preventionist, increase your knowledge and all the other things, is to get involved with your APIC chapter. So we have an APIC Virginia chapter, and somebody nabbed me to, hey, will you serve on the nominating committee next year? Sure. And then I got hooked. I went to board meetings and I met other IPs from all over the state, from different healthcare systems. I felt like I was learning so much from all of them about things. And so did a lot of work with them, served pretty much every board position since, I guess, about 2012, the first time I started being on the board. I think I've done all of them, president, treasurer, all kinds of different things.
Nice.
But right now I'm the awards person. But I also then, through that, got involved with our chapter with something national. And then that just grew. I wound up applying to, a couple of years ago, they put out a, hey, we need people to apply for positions or committees. And I did. I wound up being a nominee for one of the elected positions. I obviously didn't get it, but that's fine. Because even better, I don't know what that had anything to do with it, but right after that, I'd applied for the annual conference committee. I'd helped put together state conferences several years. I feel like that was my kind of thing. It was one of the things I was strong in. And so I applied, and lo and behold, got on the committee.
Nice.
Didn't know. I talked to somebody later that was a former chair, and she said she applied for 15 years before she ever got on. So I feel very fortunate that I got on. My 3 years term of that is ending this June. And that's why another reason it was like, okay, now's a good time. I will still be part-time PRN position. Not sure exactly what I'll be doing, but still something to use my expertise, and I still have something to do. But that's been part of what helped make the decision, is that once I get through with Nashville this year, then my duties are done.
My duties are done. It also is unique that you have your replacement in training. A lot of places, either do not or cannot do that. And that is a very helpful thing, to be able to kind of pass off the program to someone else rather than there being a gap. Nice.
I told you there'd been another hospital that had 2 openings because of retirement, and then another hospital had another one with retirement. And it felt like all they were doing was interviews and interviews and interviews. And then in addition, once they weeded it down, then they had to let the administrations of the hospital they would be working on have some say-so in it too, even though technically we are system, they want to make sure that they're on board. The leadership is on board too. Yeah. And so we already were doing interviews for the person to work with me because that person had left. And so they were like, got the idea, Karen, if you'll just give us a retirement date, doesn't even have to be specific. We can move it around. But if you'll just give us one and we know you're going to officially do it, we can use all these applicants and hire for 2.
Oh, nice.
And so that's how I said, sure. And then later I'm like, wait, why did I say that?
Now I'll have to leave.
But, it's work. Yeah. It's now I'm like, oh, I do have to leave, but that's okay.
So I think you have enjoyed your time in infection prevention. Thoroughly enjoyed every little bit of it.
Not every little bit, but most of it, yes. maybe not putting on the bunny suits this morning.
Yes, but the bunny suits do tend. My last hospital kind of went to a one-size-fits-most on bunny suits. It's like a child wearing their dad's suit, just arms flopping about. And
I felt like that today. It was hanging everywhere, and I had to go in 1 hour. Then we were doing our ARS survey, and so we went to another OR, and I went, I'm not going to miss this part at all. I'm having to put this on and wrestle with everything and all that.
Exactly. Oh, wow. All right. Well, Karen, thank you very much for your time. I have enjoyed our conversation. Congratulations on your upcoming retirement. And I hope we keep in touch. Yeah?
Yeah, definitely.